We go on to our next speaker, Dr. Professor Rajesh Sinha, who is Professor of Cornea, Lens and Refractive Services at RP Center, and is truly an amazing, versatile surgeon. As a cataract surgeon, I know he's just amazing, and I'm sure as a cornea, he would be heading too. So we are truly lucky to have him talking today on fungal keratitis, intrastromal and intracameral antifungal usage, timing, and frequency. On to you, Dr. Rajesh.
Thank you, Dr. Chitra, for the opportunity. I have a very specific topic, that is intrastromal and intracameral injections of antifungal agents in fungal keratitis. We all know that microbial keratitis is very common in India, nearly about 10 times out of the United States, and fungal pathogens are higher than the Western world. And most of our fungal keratitis, they do have a history of trauma with vegetative matter. There may not be. Essentially, this is what we see in many cases, but it may not be there. But the clinical picture is typically, dry, sometimes deep infiltrates, feathery margins, dry-looking ulcers, satellite lesions, endothelial plaques, and fixed hypopyon. And in order to treat all these, we have been using the topical antifungals like 5% natamycin, 1% voriconazole, 0.12% amphotericin B, particularly for Candida. And systemic antifungals are used because most of the times the topical antifungals don't have a very good penetration, and they don't go that deep. So systemic antifungals are required. Many times, because of the same reason, you do require repeated debridement of the ulcer. And in order to reach out to the area where the infiltrate is present, where the organism is multiplying, we have to give intracameral or intrastromal antifungal drugs. So it is like a targeted therapy. It is to place the antimicrobials in the area where it has to act, where there is active proliferation of microbes, and that is how we plan. So the indications can be fungal ulcers invading deep stromal infiltrates or deep endothelial plaque. Sometimes what happens that you have an ulcer which is it has a nice surface ulceration as well, and then going deep, and it is a proven fungal. You can manage with topical and repeated debridements, etc. But there are certain fungal keratitis wherein you don't have any epithelial breach, you have deep infiltrates. In such cases, because of the poor penetration of the antifungal drugs also, and because the superior surface is intact, the antifungals don't go very deep. So in such cases, intrastromal injections are very useful. Sometimes there are thick, cheesy, immobile hypopyons or endothelial plaques. There, you require intracameral or even intrastromal. Then there's some fungal ulcers which don't respond to combination therapy of topical and oral antifungals. So there you have to use the targeted therapy of intrastromal and intracameral. Sometimes you do have interface infections wherein it doesn't work. Again, for the same reason, there's a place for the microbes to proliferate and the infiltrates to increase. So you have to give targeted therapy there. You have to use intrastromal injections. But in conditions wherein there is a lot of melting, there is thinning of cornea, in such cases it should be avoided. So that's why I said that as far as the rationale of giving intrastromal injections in fungal ulcer is concerned, the rationale is because these ulcers are difficult to treat. They involve deep stroma where penetration by topical agents is difficult. As such, antifungals, all the antifungals have poor penetration, although voriconazole is slightly better than others, but still none of these drugs are very good as far as penetration is concerned. And that's why there's poor bioavailability of drugs. And many times, because of this reason, you have a tendency to prolong your intensive topical medication, which further causes surface toxicity. And that is where one should think about giving the intrastromal or intracameral injections. The question is how many injections to be given. Like sometimes you give an injection and you feel disheartened that the response was not that great. But even if there is some response, there's fault of progression, then that is a response. And you have to give multiple injections, at least 3 injections in the vast majority, but 3 to 5 injections are required in many of the cases. A couple of reports have even reported more injections for these fungal keratitis. But what we have noted is anything around 3, 4, 5 injections, they do well. And as far as preparation of voriconazole is concerned, which is a very useful antifungal agent, which is more often given these days, it is available in 200 milligram vial. So you reconstitute the drug with 19 ml ringer lactate to get a 200 milligram in 20 ml, that is 10 milligram per ml. Then 1 ml of this solution is further diluted in 20 ml of ringer lactate, giving a 0.5 milligram per ml, that is 50 micrograms in 0.1 ml. And that is how you give the injection. As far as amphotericin B is concerned, the intrastromal dose is 5 microgram in 0.1 ml. So you mix 50 milligram powder of amphotericin B in 10 ml dextrose, 5% to give concentration of 5 milligram per ml, and 500 microgram in 0.1 ml. In other words, and then rather 5 milligram in 0.1 ml. That's a mistake. And then this concentration is diluted with 9.9 ml dextrose 5% in tuberculin syringe to give a concentration of 500 microgram in 10 ml and 50 mics. A lot of calculations. So 50 microgram per ml, which means 5 microgram in 0.1 ml. 1 ml has 50 micrograms, so 0.1 ml will have 5 micrograms. As far as the technique is concerned, the intrastromal injections can be given under topical or peribulbar anesthesia, whichever you prefer. It depends on the patient's behavior and the patient's, how much patient is cooperative. It depends on the age, depends on cooperation of the patient, understanding of the patient. Under full aseptic condition, the preloaded drug is administered in an operation theater under the operating microscope. You use 30 gauge needle. It is introduced beveled down. A needle is inserted obliquely from uninvolved area, and you reach the edge of the infiltrate, and then you inject. When you inject, you see the amount of hydration that it is causing. And then you again go to other side. And this is how you create a barrage of hydration all around the infiltrate, so as to cover all around with the intrastromal injection. And of course, as far as intracameral injection is concerned, you wash it thoroughly, wash the anterior chamber with hypopyon, and then you inject the intracameral drug. This is one case of a proven, actually, it's a video wherein intracameral injection, first a thorough wash was given, and then intracameral injection was given, and then intrastromal injections were given all around, creating a barrage. I'm really sorry why it's not running.
You may have to exit and play it from the source files.
Yeah.
Not copied.
Do we have time to do that? Or maybe we can just complete the slides and come back.
Yeah. Do that.
Okay. So this is after the first injection. This is day 1 post-op. And then in this particular patient, and this is day 5 post-op after the second injection. And then the patient required a third injection as well. We had earlier also published case reports and case series of intrastromal injections in fungal keratitis. This was published long back in 2005 when we had injected intrastromal amphotericin B. And with 2 injections, the infiltrates disappeared almost completely, and it worked quite well. Then we had a case series of intrastromal voriconazole, wherein this is a case of a fungal keratitis, wherein intrastromal voriconazole was given and it improved significantly. Another case, which again with injections, another case with injections of intrastromal voriconazole, it improved significantly. The dose is 50 microgram in 0.1 ml. And these are some of the articles that have been published in this field. There was one article which one of these articles was from our center, and herein we compared intrastromal voriconazole versus amphotericin B versus natamycin as adjunct to topical natamycin in cases of recalcitrant fungal keratitis. And we included 60 eyes of 60 patients with proven.
Doctor, 1 minute more.
Okay, proven fungal keratitis. And wherein the ulcer size was more than 2 millimeters, depth was more than 50% of stroma, not responding to topical natamycin therapy for 2 weeks, they were recruited. And there were 3 groups, one receiving intrastromal voriconazole, one intrastromal amphotericin B, and the third intrastromal natamycin. And we found out that marginally the intrastromal natamycin was better than intrastromal voriconazole, just the healing response just by 2 days. And although that was not significant, but there was a significant difference from the amphotericin B. And another thing was deep vascularization was significantly greater in the groups of intrastromal amphotericin B. So in conclusion, the intrastromal and intracameral antifungal drugs are a way of giving direct drug delivery to the area of microbial proliferation. And it overcomes the problems of poor penetration of drug, and it acts as a depot. And of course, less epithelial toxicity, and it acts as an adjunct. You cannot say that it can alone work, but it acts as an useful adjunct along with the topical medication. So this is what I would like to say, that maybe when we feel that it's time, it's deep infiltrate, it's not responding, for 2 weeks of topical therapy, we can go ahead and give intrastromal and intracameral antifungals. And the only thing is that we have to understand that a large majority of patients, they require multiple injections, not by a single injection. Hardly any keratitis will resolve. You may require multiple injections. And it is especially useful when you have a deep infiltrate, no ulceration superficially, but you have deep infiltrate, typically like fungal keratitis, endothelial plaque, etc. Go deep, go intrastromally, inject, make a barrage, and it works very well. So thank you very much for your patient listening. And
thanks a lot, Rajesh. You actually covered nearly everything. I wonder what Shreyash is going to ask.
Extremely nice talk, sir. And who better than someone from you, like you, to present on this data, because most of the papers on this topic, I think, has been written by you and your team. So really nice to hear it from you firsthand. One question which I have, because very often as cornea consultants, we are in this catch-22 situation where you want to give a good trial of medical therapy, but at the same time, you don't want the ulcer to worsen, that you end up with a very large therapeutic graft, possibly, compromising the limbus. So like you mentioned, we know that multiple injections are required. So when do you say, I will keep trying injections? When do you say that this patient it's probably not going to work and I have to do an early TPK? Are there any specific pointers that you look for?
yeah, if it's worsening, then definitely you have to go for TPK. If it has responded, even if it has halted, there's no reduction in infiltrate, but still it has halted by the first injection, you may feel like giving the second injection to see if it's reducing. And if it has started reducing, then maybe after 72 hours further, you can give another injection. But if after the first injection, it has worsened, the second thing is that sometimes what we have felt is that even it gets, the needle tract gets infected. And if that is also happening, then it is time that you have to intervene fast and go ahead and do a TPK.
The second quick question before we ask our expert panel as well, sir, is that like you mentioned, in deep-seated focal ulcers, we find this extremely useful. But I saw you show some pictures of fairly large, widespread ulcers also where you have tried this. Do you find it to be of consistent help even in these widespread ulcers? Intrastromal?
Yes, it does. Even in widespread ulcers, it does. And what happens that sometimes when you're giving topical medication and it's not working, then it's worth trying these intrastromal and intracameral. And particularly when you're giving both, what you do is that you can remove some of the endothelial plaques as well. Sometimes these fibrinous, plaques, they are attached to the endothelium. You can separate it and then wash it thoroughly, give intracameral, give intrastromal. And in many patients, it works. If it's not working, as I said, if it's worsening, the needle tract getting infected, nothing is working, go ahead and do a TPK. But it is worth trying before you are, thinking about TPK.
Yeah.
Any thoughts, Radhika madam or Revati madam? Will also.
Yes.
Yeah, Shreyas, like you said, it was nice hearing firsthand from the flagship institute that is a proponent of many of these techniques. I only have one point to add that while giving the intrastromal, I choose to give, like you said, deep-seated focal cases, because I've not had much benefit in giving for the widespread ones. It's more dicey to give that because you need to give it in the kind of normal area or the interface between the normal area and the ulcer, which is very less in these cases. Also, I like to give it when it is microbiologically proven fungus. We, in one very rare case, burnt our fingers. It looked like a deep infiltrate of fungus, but it turned out to be atypical mycobacteria, which we realized after wasting a little bit of time. And for that purpose, sometimes if you're not able to get the microbiological sample, I do what is called as a trapdoor biopsy. I open a small trabeculectomy-like flap on the cornea so that you can reach the infection better. And even if you have a perforation, you have that flap to put it right back. And there you scrape out and take the sample. Also, the access of the intrastromal injection is a little better when we do it. Last but not the least, their group has also published this particular effect that in the end, it's a small consequence to bear, but it also invites a lot of vascularization at the time of healing when you give these injections, opens up some channels. So we have to be mentally prepared for tackling those at the time of the optical graft. These are my few takes on the matter.
True, very true.
I think
that's was seen more with recently, but also with voriconazole. Yes.
Okay. Is there any role at all of oral antifungal for any severe infection?
Very much.
Anybody on the expert panel?
Very much.
Very much.
Yeah.
Yeah. Is it when it's a scleral involvement or if it's corneal itself?
It's a corneal involvement there also. Systemic antifungals do have a role. Yes, as Dr. Radhika was mentioning, we have to be careful that it should be a proven fungal keratitis. Then only you should give all these systemic antifungals, etc. But yes, if it's a proven fungal keratitis, systemic antifungals do have a definite role.
I would like to differ here. We did a randomized trial also with ketoconazole because those days only that was the oral drug available, and we didn't find any additional advantage by using ketoconazole. Voriconazole, of course, in MUD2 trial they have tried, but then also they have showed that the incidence of TPK is not reduced or anything by using voriconazole. But of course, it was done in little severe ulcers, not the initial ones. But they said by using that, even in fusarium, there is a little bit advantage of late reinfection and other things are less. That was the only thing. But we have to consider all these oral antifungals are quite toxic, and we have to be very careful, even including voriconazole and the economic part of it also when considering this. But comparatively, regional infiltrate of the medication, I think that is more logical and rational than giving systemic.
Yeah, that's true. It's safer. And obviously, when you're giving systemic medication, you have to look for all these liver function tests, renal function tests. Everything has to be done.
Thank you. Thank you, Dr. Rajesh. We want to
Rajesh, one question to you. So this intrastromal dosage of voriconazole is 50 micrograms per 0.1 ml, but intracameral dosage is higher, actually 100 micrograms. So why is actually you need a higher concentration for intrastromal injection than an intracameral injection?
Well, difficult to say that.
Okay.
I think, while we do reconstitute, sir, I'm not sure how many of us are exactly measuring the amount which goes intrastromally. We are more keen on giving a barrage and surrounding the ulcer than actually measuring the quantity which has gone into the stroma, unlike we do, like what we do in intracameral usually.
True. That's true.
So thank you very much, Dr. Rajesh.